Good morning. First of all, thank you very much. It's an honor to be here. And I would like to ask you to pardon my English. My English is quite poor, but I hope you understand me. So, I have prepared some questions for you, because I thought you were going to be a bit tired at this time. So, first question. Do you have an antifungal stewardship program in your hospital? 1, yes, but you are not involved. 2, yes, and you think that they are a nuisance, they just interfere with your practice. 3, yes, and you collaborate with the team, or you are part of the team. 4, no, or 5, you don't know. Please vote. Okay, impressive. Okay, very good. Next slide. So, we have an antifungal stewardship for 5 years in my hospital, but I must recognize that hematologists are possibly the most difficult people to deal with them. So, I was afraid that this room was going to be full of hematologists, and now there are only 2, so I think I feel stronger now. But the first thing I had prepared is what does a stewardship program need to have to be duly called a stewardship program? Because hematologists, at least in Spain, they are very clever guys. They have their own guidelines, their own clinic bias, as they call, and they control themselves. But they are not very open to other specialists, okay? This is changing, but I think that antifungal stewardship program or antimicrobial stewardship program, to be called like that, has to be coordinated with other specialists as well. And as it has been previously very well described, it is based on interventions. We really know very well how to measure. We love to measure things, but we have to move afterwards and move and again measure. But this is the important part. And I think that Ivan has explained it very, very nicely. Education is important, and there are other interventions. Who is going to be the leader? This has been mentioned as well. It depends on each hospital. But what is clear is that if you don't have the prescriber's acceptance, you are going to fail. So in the case of hematology or in the case of intensive care units, there is usually a person in those departments who is an expert in infectious diseases. And this person has to be a member of the team, and this champion is the one who is going to tell the younger physicians to be part of the teams as well, because the young physicians will hear this person, not you. So I think this is very important. What is called in the American literature the prescribing etiquette is important, very important. And of course, you need institutional support to go and interfere with other physicians. So the team is a must to start with. And what can you do? What interventions? Ivan and Adilia has already talked about that, so I'm going to go very quickly. Education and guideline development, it's clear. You can go for pre-prescription authorization. You are not going to prescribe liposomal amphotericin B unless ID physicians authorize that. I think that's not very good advice. It can be done in a situation of crisis, but those patients are very critical, and I think that prescribers have to have their freedom. In my hospital, they can prescribe everything. So what we do is a after prescription feedback, a bedside intervention, and of course, it has been very nicely explained, to try to help them to streamline treatments with clinically and laboratory data. Okay, so for having an antimicrobial stewardship, you need some measurements. And what measurements can they be? The most useful or the most classically used are daily defined doses. For that, you need a pharmacist to help. because it's very difficult to calculate the DDDs of every patient. You can do it, but it's a big, big work. So another possibility is to have also other more clinically oriented metrics, such as what percentage of hematological patients receive antifungal drugs, for example, or to monitor the cost of antifungal drugs in each department, or you can do point prevalence studies. For example, we do 100 consecutive patients receiving systemic antifungals, and you look into them in detail. And it's useful also to have some clinical outcomes. For example, we have to present our manager twice a year how many cases of invasive fungal infections we have had, and we translate, so the manager understands us, that into money. So we have an agreement with the manager, we reviewed all the literature, and he has agreed to accept that one episode of aspergillosis cost, the literature says, between 48 and 84,000 euros. So whatever figure he prefers, 50,000, okay, 50,000. So we tell him twice a year, we've had X cases that has cost you, and he understands that very well. So he's very eager to give you diagnostic tests or to clean the air conditioner because he understands that. Another, we clinicians like to have outcomes such as how many of our patients died with a fungal infection. So you need your metrics. So are hematological patients special? Of course they are. And I have some questions for you. Question number 2. Regarding invasive fungal infections in hematology departments, in your opinion, 1, they are still a major problem that affects 20 to 30% of the patients. 2, you think that the incidence is between 10 and 20%? You think that the incidence is 2 to 5% in most centers? You really don't know the incidence, but you think that practically all hematological patients need antifungals, mainly liposomal amphotericin B, or you really don't know? Please vote. Okay. I think this is the correct one as well, but some of you think that the incidence is still very, very high. So let's look at it. There are different series demonstrating the evolution of the incidence of fungal infections, and this one is particularly interesting because it's a very large series based on autopsy. And as you can see, in red is the candida along different periods, proven with autopsy, and in the white here is the aspergillus. So incidence has decreased. And if your patients tolerate broad spectrum prophylaxis, the incidence may be as low as 2%. This is the paper by Cornely in which he studied the efficacy of posaconazole as prophylaxis in very high-risk patients, and the incidence was 2%. Okay, so one important thing is to know in your own hospital who prescribes what and why. So we did an audit of 100 patients receiving systemic antifungal drugs, and we discovered this, that oncohematological patients or physicians were prescribing 1/4 of the DDDs in our hospital. We were very surprised to see that medical wards were prescribing a lot of antifungals, as you can see here. And then the pharmacist went and looked at the cost. And here comes the surprise. Intensive care units should be your target if you are worried with cost, because they only prescribe very expensive drugs. Probably because they need it, but they only prescribe Candins or amphotericin B. Fluconazole pharmacokinetic in a critical patient is difficult, so this is a target if you are worried with cost. In the case of oncohematological patients, it was 11%, but oncologists just prescribe fluconazole in my hospital, so practically all those expenses were for hematology. And why do they prescribe those things? This is the general hospital, 64% empirically. And targeted treatment, only 21%. And in the general hospital, prophylaxis is not important, 15%. What about hematology? Look at this. Hematologists use a lot of antifungal prophylaxis, and they use it well. It's necessary. So this is probably not a problem. This is very well schematized. This is very protocolized. And they use only 3% of targeted treatment and 20% of empirical treatment. Perhaps it's here where you can do some stewardship. But do they really need a stewardship? What do you think? Do you believe that antifungal stewardship programs are useful in hematology departments? You think that one, sure, why not? Or two, no, not really. They are extremely clever and they have everything under strict protocol. Please vote. These are your votes now here. Okay, let's see. There are not many papers dealing with this. We have this retrospective study that was published in 2012. And in this study, they analyze the antifungal use in oncohematology and in intensive care unit. Those departments in this study accounted for practically 70% of the use of antifungals in that particular hospital. As you can see, the indications were quite similar to what I mentioned before. And it was very surprising to see that 40% of the prescriptions had some type of inappropriateness. Not they're completely wrong, but could be improved. The mistakes were mostly related to fluconazole that I must recognize that in my hospital is the worst used drug. We have a big problem with the doses of fluconazole, with the indications. I think it's the drug that we use the worst of all. And also with caspofungin. And it was very interesting to see that the patients that had been treated according to the protocols, according to the guidelines, had a better survival. Of course, sometimes physicians need to do heroic things for patients who are doing bad. So this was not a clinical trials, but it was a hint that if you do the things appropriately, probably you have a better response. So a couple of years before, we did a knowledge survey. We presented 20 questions. It's very similar to what was mentioned before. 20 questions to prescribing physicians, to surgeons, to intensivists, the most commonly prescribing physicians, but to all the staff, not only the senior physicians, but also residents. And you could have a 10 if you could answer everything correctly, and the mean score was 5.16. Well, they pass. But some questions were very worrying. We obtained less than 1/3 of correct answers in things like what is the meaning of Candida in respiratory cultures. Many physicians consider that they were pneumonias, or the percentage of fluconazole resistance. Everybody thought that we had a lot of resistance, and we do not. Or, for example, in Aspergillus, the indications of liposomal amphotericin B, or the use of galactomannan. So this study provided us with focused education afterwards. And when we analyzed the results by departments, you can see that pediatric infectious diseases were the top, hematologies 7, and infectious diseases 6 points. So they know a lot, but there is still a little room for improvement. Is that a problem with Spanish physicians? No, it's not, because we did something similar to European physicians, And as you can see, for example, galactomannan, only 42% of the European physicians that answered this, most of them were intensivists, knew that it could be performed in bronchoalveolar lavage or had problems with the indication of liposomal amphotericin B. So we have room for education. Then we did a survey of 100 patients receiving, we did a bedside intervention judging every DDD of systemic antifungals and giving points to the indication, to the you need an antifungal or not, to the selection of the drug, to the dose, to the microbiological adjustment when there were data, to the administration route, and to the duration. Okay, here you have overall 7.7 and hematology 7. So again, there is a little room for improvement. And as it has mentioned before, all these antifungal stewardship, when they are put in place, they are extremely effective. I brought you this recently published paper from Cambridge, in which they perform a bedside intervention. 50% of the patients included in the study were from hematology departments, and they were extremely effective in reducing the use of candins, mainly, and they saved a lot of money. So probably you will be very successful. What possibilities I see in hematological patients? I think that we have two ways. The first one, because the classical fever-oriented treatment, I think that it's overcome already. So we have two ways to go. The clinically oriented approach. You may have very severely neutropenic, high-risk patients with neutropenic fever. And they are not all the same. So this paper from Spain demonstrated that patients with febrile neutropenia could be further classified. If they had a very severe critical condition, of course they go immediately to receive antifungals. But if they don't, then you can think a little and try to find if they have some focus. So from this patient, 53 had non-focus fever and 32 had a focus. Then, depending on the origin of the infection, you prescribe different antifungals. Not all the patients receive exactly the same. When the patients with initially non-focus fever receive a CT scan and galactomannan, some of them were found to have pneumonia. But there remain almost 40% of high-risk patients with fever, with everything negative, that did not receive antifungals, 40%. What happened? Nothing happened. All the patients that finally had a fungal infections were in the arm that had received antifungals. So antifungals not prescribed in 40% of febrile neutropenias, and on top of that, doing this, 77% of patients who did receive antifungals really didn't have a fungal infection, but they received antifungals, and probably at that moment they should. The related mortality of fungal infections in these patients is very low, is much higher in other populations. So what happened with the cost? As you can imagine, the cost was clearly reduced, mainly because antifungals were used less frequently. And here in red or in pink, you have the cost of the monitoring and diagnostic tests. If you compare with a single episode of aspergillosis cost to the healthcare system, to perform galactomannan, PCR, beta-D-glucan, it's nothing. It's 2%, as Rosemary demonstrated. So what other thing you can do? From the clinical point of view, you can go as an infectious diseases person and try to help them. We did that, and in the whole hospital, we were able to give a therapeutic advice at our initial visit in a good percentage of the patients, approximately 20-something%. The rest, everything was okay. The most common advice was to de-escalate the antifungal or to stop the antifungal. At the end of the day, when the patient was discharged, the most important mistake was too long therapy or no adjustment to microbiology tests. It doesn't mind what microbiology tells you. The patient is doing well, and you are not going to change your drug. So we have to change that. And let's compare what has happened in hematology in our 5 years. This was our first study, the one I showed you before in the General Hospital. And this is just for hematological patients. From 156 patients, 58%, everything was okay. In the remaining patients, we gave some advice, but they hear us, or they did what we suggested only in 11%, and in 31%, they didn't change their minds. This year, things have changed. 85% is completely right, and there is only 4% in which the attending physicians decided not to hear our advice. But as you can see, 5 years of working together has had a major impact. And here were our advices: to stop antifungal, 7%, to change drug, 5%. Those were the most common. And this has a meaning for the manager, because as you can see, we were spending approximately 4 million euros in antifungals in a hospital with 15 to 1,800 beds, 60 episodes of candidemia per year, and let's see, 15 episodes of aspergillosis. So we were spending a lot of money, and without a single problem of us stopping antifungals and the patient dying, not once. We are very careful. As you can see, you will have a major impact that will pay for half a day physician working in the antifungal stewardship. So we are started saving $500,000 per year. Of course, that's at the beginning. Afterwards, it's much difficult, and you tend to stabilize. And in this saving, everything has to receive the benefits, not only the leaders of the program. And here, the hematologists present the data to the manager and look at the reduction in expenses in the bone marrow transplantation team. Very, very significant. So the other way is not just clinically oriented, but based on biomarkers. And in that case, I think that the paper by Rosemary Barnes was, at least for me, was like opening my eyes. No? It was proving that you can do these things even in a hematological patient. She published a large amount of high-risk patients given itraconazole prophylaxis, and she was sure that the levels were okay. So when the levels were okay, the levels were okay. So they also performed galactomannan and PCR twice weekly and during fever in non-transplant patients. They had CT scan, and in this situation, when the levels were okay, no empirical antifungal therapy was initiated. What were other findings of their work? First, biomarkers alone cannot establish the diagnosis of aspergillosis. Look at the positive predictive value of the tests alone. If you combine both tests, well, your positive predictive value increases a little, but it's like throwing a coin, it's 50%. However, the combination of biomarkers was very accurate, excluding aspergillosis. I think that they were the first ones to prove that. Look at the negative predictive value of more than 98%. So here we began to think, perhaps it's possible to stop or to withhold therapy with confidence. Other newer biomarkers, yes, there are the PCR, the lateral flow, the electronic noses, other things. I will show you some data. We were having a lot of problems in my hospital with galactomannan. We were seeing a lot of false positives in hematology, and they were, and it was causing a lot of CT scans, a lot of unnecessary expenses in antifungal drugs. And we published some years ago that the transfusion of platelets of one strand, of one Fresenius in our hospital, was a cause of false positive. So when you take samples for galactomannan, take them as far away as possible from the transfusions. But you have to remember, and this has been mentioned before, there are other causes of false positives for galactomannan. There are also many causes of false positives for beta-D-glucan. Here you have some studies. This was performed as well in patients, in hematological patients, searching for invasive aspergillosis. And they were using a combination of galactomannan and beta-D-glucan. Here you have again, the positive predictive value was slightly better. We are reaching 62%, 70%, but look at the negative predictive value. Again, very good. Beta-D-glucan showed the highest sensitivity for candidiasis and for pneumocystis. It's extraordinarily useful for pneumocystis, and that with our oncological colleagues, we use it a lot because they are always very frightened of pneumocystis, and they are prescribing a lot of treatment for that cause side effects, neutropenia, etc. So if you have a negative beta-D-glucan, you can say, stop the Septrin, you don't have pneumocystis. These authors describe more causes of false positive beta-D-glucan: the administration of immunoglobulins, gram-negative infections, and albumin administration. So always try to obtain the samples for testing far from these other treatments. And in this paper, they conclude, based on our experience, we propose to screen with beta-D-glucan and galactomannan only in febrile patients or individuals with very high risk, not everybody. And why not everybody? Because, as you know, imagine that you have a test with this sensitivity and this specificity. If you apply it to a population with an incidence of disease of 15%, you will have this positive predictive value and this negative predictive value. But if you apply it to a population who is already receiving posaconazole or micafungin and has a pretest probability of having an invasive fungal infection of 2%, then probably all your positive results will be false positive results. And this has been proven by Dr. Duarte in Spain. He published in Clinical Infectious Diseases last year this very important paper. He analyzed the efficacy of galactomannan in patients, in hematological patients who were receiving prophylaxis with posaconazole. And when used for a screening twice or thrice a week, the positive predictive value was 11%. So imagine, 90% are false positive results with all the tests you have to do to exclude, et cetera, et cetera. However, the test was very useful when you have a patient in which you have clinical data suggesting fungal infection, CT scan or whatever. In this case, the positive predictive value was high, was good. So they suggest that serumgalactomannan testing in patients with effective prophylaxis is not useful as monitoring because you are going to have either negative or false positives most of the time. But it is useful to diagnose patients with suspicion. And we haven't published it yet, but we did the same with patients receiving micafungin prophylaxis because not all hematological patients tolerate or have posaconazole indication. Some of them receive micafungin prophylaxis. We analyze this number of serum samples and summarized in the paper, again, we saw exactly the same. The positives we had, only 7% were true positives. So it's really a loss of time. So another possibility is more sophisticated, but not every center still have Aspergillus PCR, is to combine, for example, galactomannan and PCR or beta-D-glucan and PCR. We still don't have many data, but they are very encouraging. For example, this paper published last year showed that combining galactomannan and Aspergillus PCR, you increase your positive predictive value. Now we are nearing 90%. So this is a completely different situation, and you still have a very high negative predictive value. So I think that this is changing very rapidly, and probably physicians, hematologists have to think about it, but probably in following guidelines, they will say that if you have all these tests negative, probably you can stop therapy. And remember, no test alone is able to indicate therapy. So from the microbiological point of view, our problem is who is going to need all those tests? Every hematological patient 3 times a week? We cannot perform PCRs to all these patients. So probably we will have to design or to create a strategy and decide which patients deserve all our efforts and which patients just must receive prophylaxis and nothing else. So probably universal screening with PCR that is not possible. Other tests. I think that this afternoon or tomorrow you will hear about the lateral flow device. I have no personal experience. We tried some samples, but they didn't work very well. But it is published in Critical Care this year, last year. Look at the excellent negative predictive value in bronchoalveolar lavage. So very easy to do test, very easy really. It's like a pregnancy test. It can be done everywhere. And negative predictive value of 96%. And again, TDM. TDM is extremely important, of course, for pediatricians it is, but for adults as well. We have just published this paper in which, as you can see, the first sample of voriconazole had only 62% on target. However, when they sent a second sample from the same patient, the percentage on target clearly increased. So my final slide is this one. I think that we need to learn how to work together, and we need to learn from each other. Infectious diseases physicians need to learn a lot about hematological patients because we may not be aware of many of the things that are happening to the patient. Hematologists have to improve their diagnostic workout. We know that their patients is probably more difficult to do some tests, but it is very important, and we all have to share knowledge and forget our egos. So with years and years of working together, I think that it is possible to do a very nice team. This is the team of my hospital. This is the people from the laboratory, from the pharmacy. They are very, very important, from the infectious diseases, and this lady is an hematologist here, but they are all oncologists, solid organ, well, different people. Here you have some of the publications we did along the last years, and I will be happy to send you the PDFs if you are interested. And thank you very much, Samir. It's an honor to be here, and thank you, all of you, for your attention.